Well, hello everybody, and welcome to a HERO webinar jointly sponsored this time with the American Journal of Health Promotion. And the reason that we're jointly sponsoring this one is this is an encore production, you guys. We had under Michael O'Donnell's leadership, a similar presentation last year by our guest today, Mitesh Patel and Kevin Volpp. And as we did last year, we're going to be talking about behavioral economics with an emphasis in some of the findings from their research in physical activity. The reason I have them back is because a new feature of the journal that I instituted at the end of last year was our editor's picks and our papers of the year. And congratulations to Drs. Patel and Volpp in that this paper was picked as one of the best we thought was published last year by the journal. We are in good hands today as it relates to the science. We had just had, coincidentally enough, a webinar a few weeks ago on the policy side of health promotion. We had a lawyer and a business leader talking about what's going on in terms of the politics of this. And Kevin, I didn't tell you this, but one of the things that also prompted me to feel like it was time to get you and Dr. Patel back on is I was reflecting after that policy webinar on something I heard from you at a conference. I bet it was about 5 years ago, and it was after the presentation you had made. And the audience was asking about policy and science issues, and you said something interesting that stuck with me. You said most often scientists are frustrated with politicians or public policy because there's such a long lag between when the evidence is persuasive and clear about a new device or a new med or new procedure, and too often the policy lags too far behind. You said at that time, in the case of financial incentives, especially as they're used in worksite wellness, you felt policy was running ahead of the science. So one of the things I'll look forward today after your presentations is discussing just that, where we're at in terms of this alignment between what we're doing and what the science is saying we ought to be doing. So thank you guys for joining us as always. And let me introduce both of you by surveying a little bit of what's available for our listeners on your respective web pages. And boy, there's a gold mine of things to be able to find about you and learn about you throughout the web. So obviously just Googling in our presenters' names will get you all started. But you all may know that Kevin Volpp is the Janet and John Haas President's Distinguished Professor at the Department of Medicine. If you look at his Perelman School of Medicine website, it's a great place for you to get started on his series of publications and other honors. If you look ahead to their work at the University of Pennsylvania, there's a great website you all to spend some time on called the Center for Health Incentives and Behavioral Economics. So this is the center's website. I happened to pick the physical activity page of the website so that you could also be reminded that you can find Dr. Patel there as well. In introducing you, Dr. Patel, I'm reminded that I think I went in the wrong order. I meant to start with your presence on the Wharton School's page, Dr. Patel. I love this page too because you can, in addition to see an overview of your research interests, you also can see all of your research background. If you stay on some of these websites, you'll see that Dr. Patel's study that he's going to feature today really made the rounds, you guys. This was picked up across the United States, in Australia, in the UK, in India. I know that there's a great summary here, but you guys are going to get a great summary from Dr. Patel. I'd also commend Dr. Patel for having won an early career research award. The subtitle is interesting to me in that here he's credited for finding that incentives, at least as used in discounted insurance rates in this study, are not effective. So good for you and for your colleagues for crediting you for finding out things that work as well as don't work. And you are joined, as I said earlier, by your colleague, Dr. Volpp, who you also can find on the Perelman School of Medicine page. These publications are quite up to date, Kevin, as you and I discussed the other day. But you can also find Kevin, as you can, Dr. Patel, on the Wharton School page. You got to get after them, Kevin, because as much as I like this one better because it's actually got a longer portfolio of an extraordinary research output of you and your colleagues here, it's not quite as up to date in things like your awards and your publications. So let's prompt them. Kevin, I was looking at several of your other web pages today. I especially enjoyed the talk you gave in something called Biz Talks. It's back a few years, but I think you gave a great overview, and more than our audience will have time to learn from you today. So I'd really commend folks to jump over to YouTube and simply put in Kevin Volpp, and you'll find some of his interesting background. Kevin is also a leader with a group called Val Health, and Val Health too has a wonderful website that also shares a white paper that's very detailed for those of you who are perhaps new to this area of behavioral economics and want to learn more. We've had the co-founder and president, Karen Horgan, has been my guest on webinars in the past, so welcome back to Val Health as well, and you can learn more about Kevin there. And then finally, as I said, do scroll through some of Val Health's website to find some of those easily available resources. And then finally, let me commend you, Kevin, for a new study that's recently being published about you and Dr. Polsky are embarking on a 4-year project to develop and test algorithms aimed at predicting adverse health events in real time. That sounds really cool, so stay tuned on that one. And then as I turn it over to you guys, just be reminded too that you're going to hear these guys talk about wearables and devices and how we have interesting interaction between the things that we're monitoring in worksite wellness and things that we're associating with financial incentives. We're also proud here at HERO to be featuring this month the report that Dr. Jessica Grossmeyer led in terms of our identifying how wearables are being used throughout the world and throughout the field of worksite wellness, particularly here in the United States. So with that as background, I'm going to ask my colleague Maren to give you guys the screen so that we can head over to your presentation. And with that, Kevin, give me a very quick reaction to my reminder that you said that the science had, in your view, some years ago, been running ahead of the policy. How are you feeling about that now?
Yeah. Well, first of all, thank you for the very generous introduction for both me and Mitesh. Much appreciated. I think the science has been catching up. There's been a lot of really good work done on this in this area since I made that comment a number of years ago, and a lot of innovation in terms of different kinds of ways of applying behavioral economics in terms of incentive designs and benefit designs more broadly. So I'm not sure I would say the same thing today, which is interesting. I think a lot of entities aren't using the evidence as well as they might, but increasingly there is more and better evidence about what one could do if you want to optimize how your program is designed.
Yeah, thanks, Kevin. Well, and thanks to you guys, that gap is getting closed. Your productivity has been absolutely amazing, as is Dr. Patel. So, Dr. Patel, thank you for being on screen with us, and you've got control, if I can tell from where I sit. So, have at it.
Great. Well, we also wanted to mention that Kevin and I are both on Twitter, so if you're interested, feel free to follow us and keep up with all of the latest work and share any insights you have on the webinar. So we're really excited to be here to talk about behavioral economics and physical activity. I'm going to give a little bit of background and go through 3 of the most recent studies, and then Kevin will talk about how these programs can be more broadly applied in real-world scenarios. So in background, many of us know that physical activity is overall really good for our health. Higher rates of activity have been associated with lower rates of cardiovascular disease, diabetes, obesity, hypertension, and even all-cause mortality. But more than half of adults in the United States actually don't get enough regular physical activity to achieve most of these benefits. Many workplace wellness programs and employers have been launching programs to try to address this. And more than 85% use financial incentives for health promotion, including ways to get physical activity. The rapid growth of smartphones and wearable devices has really helped to fuel this by helping us find ways to be able to monitor these activities in people's daily lives and to launch these interventions at broader scale. So our objective was to use these types of devices and to specifically test different designs of financial incentives to increase physical activity. The first study I'll talk about includes both financial incentives and then social comparisons through a study that we did here at the University of Pennsylvania. So this is a 13-week randomized controlled trial with a 13-week follow-up period. We asked employees at the University of Pennsylvania to form groups of 4 and download a smartphone app in which they could use to track their step counts. And we gave everyone a step goal of 7,000 steps per day. This is cited by the American College of Sports Medicine as kind of the minimum amount of activity that an individual needs to start attaining these health benefits that we talked about. Each participant was given feedback on whether or not they achieved their step goal for the entire 26-week or 6-month study. As I said, we enrolled adult employees from the University of Pennsylvania Health System, and our primary outcome was the mean proportion of participant days that they achieved this goal, or the proportion of time that they actually met their 7,000 step goal. In 2 arms, we gave them just feedback, and specifically, we wanted to test whether giving people feedback at the median or the 50th percentile, or feedback at a higher level, the top quartile or the 75th percentile, would be more effective. Many smartphone apps, wellness programs, and so on often use leaderboards in which they display how the top performers are doing. But there isn't much evidence to determine whether or not these are effective. So here we specifically wanted to look at whether giving feedback at the norm or at the people who are doing the best would be most effective. We also had 2 arms where we included financial incentives. And the way these were designed was in the form of a lottery, where every week each team had a 1 in 5 chance of winning $35 and a 1 in 100 chance of winning $350. And this was operationalized through them picking a lottery number. And if the lottery number matched 1 or 2 digits of the winning number, they'd be eligible for the lottery, but only if their team averaged at least 7,000 steps for the week. Now, mathematically, this comes out to about $1.40 per day, or about $550 over the course of the year, which at the time was about the average that a typical wellness workplace program was using for these incentives. Now that number is much higher, about $700 per year. So here we're testing, again, feedback at the norm or the top performers, both with and without incentives. Here's what we found. The arm that performed the worst was the 75th percentile, or the arm that gave feedback to just the top performers. The one there, they achieved their goal about 27% of the time. The arm that was the most effective was the one that combined both the normative feedback, what was the average or the median, with financial incentives. And you can see that this led to, on a relative basis, a 67% increase in the proportion of time that people achieved their goals. Now, it's important to keep in mind that, again, all of the 2 incentive arms were the same magnitude, and everybody was given some type of feedback. And so it's impressive how just little changes can have such a dramatic impact on outcomes. In summary, in this study, we found that smartphones were an effective method to track physical activity. We were able to enroll about 280 people very quickly and had more than 95% finish the 6-month trial. And this was, of course, a sedentary population. The average step count was about 3,000 to 4,000 steps per day. So we found that social comparison feedback to the 50th percentile with incentives was the most effective for increasing physical activity. And this helped us think about future designs in which we might test different frequencies of financial incentives or find other ways to further leverage social incentives in combination with financial incentives. This kind of takes us into the next study. In the next study, we wanted to look at the way that financial incentives were framed. The typical approach that we see in most programs is to offer an incentive in which individuals need to do some type of behavior, be physically active, lose weight, attend get their flu shot, or whatever it might be, and then they get rewarded. But we felt that there are ways that we could use some of the behavioral insights to really test other ways. And so in this study, we enrolled, again, 280 people. We worked with, this time, the university's employees. We enrolled people that were overweight or obese and had them download the same smartphone app for a 6-month study in total, and randomized them to a control arm, an arm where they received kind of the typical approach, standard gain framing. Every day you met the 7,000 step goal, you earned $1.40 per day. This is the same amount as we talked about in the last study. A lottery arm, which is similar to the other one, except it's a 1 in 5 chance, a daily lottery instead of a weekly lottery, so a 1 in 5 chance of winning $5 or a 1 in 100 chance of winning $50. Again, on an expected value, it's about $1.40 per day. So we're just changing the way the incentives are framed, not the value. And then a loss framing arm, where each month, each person's told that they had $42 put in a virtual account, and every day they don't meet their goal, they lose $1.40 per day. So all of these participants were paid in the form of a check at the end of the month. So we kept the way we paid people the same. From an accounting perspective, if you reached your step goal 10 days in any of the intervention arms, you should receive about $14. So there's no real difference from an accounting perspective. But from a psychological perspective, there's a big difference, because as much as people like to gain $1.40 per day, they really hate to lose $1.40 per day. And this really played out in the results. So we see the control arm achieve their goal a little bit under 30% of the time. The gain incentive was a little bit more, but statistically no different than not paying people at all. The lottery arm was a little bit higher, but the best performing arm was the loss framed arm, in which we gave people, we told people up front how much they had, and we took it away if they didn't meet their goal. This was a 50% relative increase. Again, not changing the amount we paid or how we paid, but the way that we framed the incentive up front. So I'm going to talk about one more study. Many people are interested in kind of the intersection between using financial incentives and figuring out how to frame them, and also team-based approaches where there are competitions or people working together. This might find ways to both marry financial and social incentives. And so we wanted to test what was the best way to design incentives in teams. In this study, we worked with Independence Blue Cross and enrolled 304 of their employees into a similar 6-month study using the Moves app to track their physical activity. There was a control arm which just got daily feedback, and then there were 3 incentive arms. The first was an individual incentive in which every other day a team was picked as the winner, and each person on that team got $50 if they individually met the step goal. In the team incentive, again, one team was picked from the group as the winner every other day, but in that arm, everybody on the team got $50 only if all 4 people met the 7,000 step goal. So this is really kind of 2 ends of the spectrum. Is it based on your individual performance, or is it based on the performance of the entire team? And then we had a combined incentive, which tried to balance these 2 things. If your team was selected as the winner and you were in this arm, you got $20 if you individually met your goal, and then you got a $10 bonus for each team member that met the goal. And we specifically want to test which one of these would lead to the most activity. So here's what we found. In the control arm, people achieved their goal about 17% of the time. Again, a very sedentary population, mostly sitting at their desks in this workplace. The individual arm did a little bit better, but not statistically different. The team arm was actually the same or slightly worse than the control arm. We found that not many teams ever actually won the reward. It's really hard to get everyone to meet their goal when they're chosen. But the combined incentive was actually almost double, with them achieving the goal 35% of the time. And again, the incentive amount was the same here. We just varied how much of it was based on individual versus team performance. And we really find that the combination of individual reinforcement with social support was the right way to balance financial incentives in this study. So with that, I'm going to hand it off to Kevin, who's going to talk about some of these insights more broadly.
Okay, well, thank you. And Mitesh has been a great colleague and partner in a lot of these studies. What I'm going to do is talk to you a little bit about some of the broader picture in terms of behavioral economics and health behavior and some of our thoughts on where the field is going. The basic realization that I think is important to come back to is that there's lots of work that shows that just giving people information about their risks, their benefits, often doesn't change behavior. We can think about that as necessary but not sufficient. As you know, a lot of employers have moved into using economic incentives of various kinds to motivate employees, probably about 80–85% of large employers. But a lot of those programs have the substantial limitation that they assume people are perfectly rational and that they're dispassionately able to calculate the probabilities of all the different outcomes that will happen to them. They're able to have a clear sense of how good or how bad they feel about different outcomes, and then through a process of backwards induction, figure out which choice path has the highest net present value. And most people don't make decisions that way. They certainly aren't making day-to-day decisions like, should I have another cigarette? Should I have another chocolate chip cookie in that way? And what behavioral economics has really helped us to better understand is ways in which that standard model of economic rationality, ways in which that needs to be enhanced. So people tend to make decisions based on the immediate costs and benefits, how choices are framed, based on what other people around them are doing, how they feel, how the choice environment is structured, the number of choices, the order of choices, is there a default, and so on and so forth. So one of the things we want to highlight is that whatever you do in terms of health incentives, you have to think more broadly about where that fits in terms of the health plan in which the health incentives are being offered. We've looked at a lot of health plans and worked with a number of employers and health plans on trying to improve their health plan design. And one very common observation is that health plans tend to be far too complicated. There might be 60, 70, 80 pages of small print like this in the Guide to Benefits, where you have, in essence, a giant incentive plan with lots of different cost-sharing elements built in, which people, by and large, don't understand very well. And part of this is because a lot of the cost-sharing type elements, like coinsurance, in essence, make it impossible for people to calculate how much an episode of care is going to cost them. So let's say I have a plan that says it's 10% of an ER visit. An ER visit could cost $500, it could cost $5,000, it might even cost $25,000. And I have no way of knowing what it's going to cost. Contrast that, for example, with a copayment, where we could say exactly what it's going to cost you if you go to the ER ahead of time. One of the interesting experiences our group has had is working with one of the major health plans, Humana, on designing a new health plan, which is called Humana Simplicity, which is now on the market. And it's simple in a few key ways. One is that the whole plan description fits on 2 pages like this. The second is that it's copayments only. So if we look at the copayment for going to your emergency room is $375. If you end up getting admitted, it's actually $0. If you go to urgent care, it's $100, and that's on the line above, so you can just very clearly see what that contrast is. And we've now followed this by doing work through Val Health and in other contexts where we've also been trying to think about how do we apply these concepts and thinking about making plan design itself simpler so that the underlying incentives that are embedded either within the benefit design or in efforts to do health behavior can be more clear, more transparent to individuals. This is a result of a big research project that we did within our center that my colleague Scott Halpern led. And what we did here is we built on some earlier work we had done among employees at GE, which showed that a $750 financial incentive tripled smoking cessation rates among employees at about a year, led to benefit design changes throughout GE for all their employees in the US. In this study, what we did is we gave people the opportunity to put some of their own money at risk, in this case $150, and then we matched that roughly 4 to 1. So as soon as you put down $150, you had $800 at risk, which you would lose if you didn't quit smoking. What we found was very interesting. About 52% of people who were willing to put their own money at risk actually quit smoking, which is an amazing quit rate. So the standard quit rate in the US population is about 3% per year. So 52% of people quit. However, only about 15% of people who were given this offer actually put their money at risk. So as with many programs, it's very hard to get people to engage and certainly to put some of their own money down. What we worked out with CVS was an interesting evolution of that, where CVS was, of course, very intrigued by the high quit rates, said, how do we get more people to engage? What we did is we lowered the participation rate, lowered the participation amount to $50 from $150, and then CVS matched this 14 to 1. So an individual put down $50, CVS would provide $700, hence the name 700 Good Reasons to Quit, and instantly the smoker who was trying to quit would have $750 at risk, which they would lose if they weren't successful in quitting smoking. We're in the process of evaluating this now, very interested to see what happened in terms of engagement rates and quit rates. But it's the kind of benefit design innovation, which, coming back to Paul's question in the introduction, I think has really helped us build data, build evidence on what kind of approaches work well. Here's another example. Another hot area is really thinking about how to develop time-limited incentives that help people form better habits and have sustained effects. This was an example of a study we did among 8,000 school children in 40 different elementary schools in Utah. We offered either a 3 or 5 week financial incentive, 25 cents a day. So the total amount was very small, $3.75 in the one case, $6.25 in the other. And we measured what happened during the course of the intervention in terms of percent of kids consuming fruit and vegetables, and then what happened after the incentives were turned off. In essence, what we observed was that the fruit and vegetable consumption rate doubled from about 40 to 80% during the intervention, and about half of that increase was sustained even several months later. So for an investment of $3.75 or $6.25, pretty good deal that we got 50% higher rates of fruit and vegetable consumption even several months later. But this is the kind of research which we're doing more and more of, other groups are doing more of, where we're really trying to think about how do we achieve sustained effects, even if it's not going to be a time-limited incentive. In many employer benefit contexts, the incentive is going to be ongoing. So it's a different, in some sense, an easier goalpost. But in many health promotion programs, there's obviously the goal of trying to change behavior as inexpensively as possible for as long as possible. I want to give you a couple of examples of how we've put this into practice through our work with Val Health and working with various entities around the country. A lot of what we've been doing is taking some of this research and thinking about how do we build something that can be easily deployed off the shelf. Val Health Rewards is an example of that, which in essence uses a regret lottery type approach, similar to what we've tested in our research. We found in walking programs we can get pretty good sustained effects. Here's some examples out through 11 weeks where you see a pretty good sustained effect. And then in a lot of different contexts, we test head-to-head different ways of designing incentives to see what actually works best in practice. So here's an example where we've tested Val Health Rewards versus a standard gift card from Amazon or iTunes gift card. In terms of portal registration, you can see we get much higher rates using Val Health Rewards. Another example is a raffle for a telehealth app registration. Always hard to get people engaged. We're getting much higher rates for not that much more money. And then finally, in terms of a harder to achieve outcome like tobacco cessation, we're finding that if we can redeploy some of the money that's used in terms of premium adjustment, that can actually move behavior much cheaper than premium adjustment. An example here is a $1,000 surcharge got us at 50% engagement. With $110 of Val Health Rewards, we're actually at 69%. So a pretty dramatic difference. So let me stop there, and we're happy to take any questions. Mitesh has patients to take care of this afternoon, so I think he's going to have to step out shortly. But happy to take any questions you have and talk further. Thank you.
Yep, we can take it now. Hey, thank you, Kevin. That was fantastic. And I need to tell our audience that the most frequent question I get is, how can I get a hold of those slides and how can I get a recording of this? I am sorry to say that you had to be here on this one. This is indeed an exclusive opportunity because Kevin just reported on some
Yes, we have a pretty good web presence. You can find out a lot of information about us and our work through our various websites. And if there's particular papers people are interested in, we're happy to send those out.
Yep, and once this stuff is published, Kevin, I might approach you yet again to see if we can post some of these slides once it's out the door. But this is our time that we enjoy following up that great presentation with questions from our audience. I'm already getting lots of interesting reactions, great information according to Kim Haug, so thanks for that, Kevin. And we're going to jump into polls in a second as well, because that also sparks even more debate, it seems, about what you've just shared. But allow me to offer or ask just a couple of questions to get us started. But before I do that, let me see if I can, let me see if I can also remind our listeners, do I have it back? Seem to be quite getting down to, okay. Well, I'm going to hold on that, Kevin. Let me ask you first. You presented so much interesting stuff, but the CVS one, the one that they've used your data and your findings to talk with you about changing the levels and changing the level of commitment in the deposit contract, if you will. One of my favorite papers that I emailed you about, I don't think you were first author, but it was a commentary, I believe it might have been in Health Affairs, where you all reflected on a post-study interview you did with folks a year later in a smoking cessation research, where you asked them simply, how much would it have taken you to quit smoking? And I seem to recall that the number was on average somewhere around $2,000, $2,300. What was interesting about that report of these folks you interviewed was the range was anywhere from, I would have quit anyway, there was a great intervention, thanks for the money, but I would have done it for zero, to $1 million. You couldn't have paid me $1 million to quit smoking, and everything in between. So I'm so interested now to see that you are playing with this level of reinforcement and deposit contract. What are you? Give us a sense. Have you ever moved in mentally, taking in account sort of all the income levels that you deal with? What you venture would be that sweet spot?
Yeah, no, it's a great question. So obviously, in general, the higher the incentive, the bigger the effect, but there are diminishing marginal returns. As that incentive increases, you expect that curve to level off. I guess for those of you looking at the camera, I should go this way. But, you know, the CDC has estimated that the annual cost of having an employee who's a smoker versus a non-smoker, an incremental cost might be somewhere between $3,000 and $4,000. So in any case, we're well below that. The numbers we've been using in these studies reflect the outcome of a variety of conversations with benefits managers, large employers, where we've asked, if we were to use an incentive of this kind and we showed a significant increase in smoking cessation rates, would you use this in practice? And the answer, at least for some of our big partners like GE and CBS, has been yes, to $750, $800. So that's sort of how we've settled on that. It's sort of a fraction of the economic value to getting somebody to quit. Keep in mind that first figure I cited, the $3,000 to $4,000, that's per year. So if you have an employee who stays with you for a long time, the value of getting somebody to quit smoking is really enormous. I mean, obviously to the patient or the employee, him or herself, but also to the employer, to the health plan. So I think there is latitude there. A lot of the challenge going forward is really trying to think about how do we do even better. We've found in these studies that we can triple smoking cessation rates, but that means going from 5% to 15%. And that means that there are a lot of people who are still not quitting. So a lot of what we're trying to do now is really try to innovate further and figure out how do we get those rates up higher, and of course trying to do it as efficiently as possible in terms of the cost.
Yep. Let me ask you about loss framing. Some of the issues that keep getting brought into your arena relate to the ethics of this and to the fun factor in wellness and to what extent we're doing social engineering here. The more I listen to you guys, the more I do think of Orwell and some of the interesting ways that you guys continue to look at the difference between teams and lotteries and deposit contracts. You talked about loss framing being more effective, but what about this whole carrot stick debate? Have you found in your work with organizations that they tend to avoid some of these more effective approaches simply because they worry about the fun factor and the sense that those who don't get it will feel like you've just used a stick?
Yeah. Well, it's a very good question, Paul, because as you know, there are trade-offs here between potentially having high effectiveness and the palatability and enjoyment of being in a program. And inherently, part of why loss aversion is so effective is that people don't like losing money. So if you set up a program where people feel like they're getting penalized left and right, that's probably not going to be an extremely popular program. On the other hand, selectively using loss aversion in a program can be very helpful in improving its effectiveness. So that's the advice we generally give. I think you need to pick your spots and really think about in what types of situations is loss framing helpful. There are obviously different degrees to which you can do this. You can actually penalize people and charge them more. You can take the money away. You can have them put their own money at risk and lose that. You can deposit the money in a virtual account for them and they can lose that. So there's sort of different degrees with which you can do that. It also depends on, is this a program in which everybody wins and we're just framing the gains as a gain or a potential loss? So for example, let's say everyone's in this program and if they quit smoking, we're going to give them $500. You can give them $500 if they quit smoking at the end of the period. You can put $500 in a virtual account for them, which they would lose if they don't quit smoking. But nobody in that case is actually losing money relative to where they started. So there's all sorts of different ways you can do this. I think benefit designs have actually been, in some sense, more punitive than a lot of what I've just described, because in many cases there are real penalties. If you are a smoker, you pay more. for example, and there's no frozen carrot element to that. That's a true stick.
You bet. Yeah. Well, we're going to jump into a couple lotteries. I've got a good number of questions here, Kevin. Just a note for our participants that we're going to go right to the top of the hour because according to my dashboard, everyone is super engaged here, and Kevin assured me that he can make time for us. But before that, is my forum up on the screen right now? Just a reminder, as long as we have such a good number of folks here, many of these kinds of issues and many more learning opportunities are coming up. So we're eager for you all to get ready to come to see us in Phoenix on September 12th through 14th. We have a whole bunch of pre-forum opportunities also in healthcare and university, and we have our first ever CMO summit coming up in Phoenix. So we look forward to seeing you all there. And then later in July, Dr. Jessica Grossmeyer is going to be hosting Monica Warline. For those of you who are HERO members, she was here this summer talking about issues of compassion and gratitude and how it relates to mental health and emotional well-being in the workplace. She was fantastic, so we are so delighted she's agreed to join us for one of our next webinars. And then to give you a preview of things coming up to the forum, we're also going to be talking to two of my favorites, Megan Hammis and Sarah Johnson from ProChange are going to join us and be on one of our future webinars. So let me ask you this because Dr. Volpp ended up with some very interesting work that he's doing in healthcare systems generally. I know many on the phone tend to be focused on worksite wellness and the incentives that we've been doing there, but as you can see, in both the studies I previewed and some of these last studies, Dr. Volpp is quite busy in health systems writ large. So one of the questions he asked us to think about together is health insurance plans can be thought of, just as I think you summarized nicely just now, Kevin, as health incentive plans tied to health services. How much, those of you who are working with employers and helping with benefits design, how much do you use value-based principles in your designs? Are you using lower cost sharing for higher value services? The Business Healthcare Action Group crowd is certainly a fan of that approach. Are you using raised cost sharing for lower value services? Are you thinking about a combination of A and B, or have you done neither? And Maren is going to launch that for those of you who might be new to our webinars. I'm not looking for you to write your answer in our little comment box as much as I'm giving you the opportunity to hit a little dial button there that will give you the opportunity to vote, and I'll watch as our votes come in. But Kevin, one other question as we're thinking about that and our audience is voting on that. You talked about lottery. I think it was your research that also related to how in one of your studies the use of lotteries tended to be more popular among our lower income participants in these programs. And I've had Bruce Sherman, for example, on, who I think is on today's webinar, who has talked about this very interesting paradoxical finding he's had in large data sets he's looked at, where some of our lower income, lower wage workers are not as apt to take advantage of some of these financial incentive opportunities. So I wonder, could you reflect a little bit about the demographic differences you're finding in your research writ large between not just wage, but other characteristics of the population and what works better in terms of lotteries versus attainment incentives and others?
Sure. Yeah, this is very much an active area of research trying to figure out what sort of personal characteristics relate to success in different kinds of interventions. The finding about lotteries is interesting because a lot of the popularity of lotteries really relates to the human tendency to overestimate small probabilities, in particular small probabilities near zero. And I think that's seen in the general population when you look at the popularity of the Powerball, for example. Lots and lots of people play the Powerball, even though the likelihood of winning is very close to zero. You know, often it's 1 in several hundred million. So people tend to overestimate small probabilities. I think that happens more in lower income populations. So for example, if you look at spending on lotteries in general, relative to people's incomes, it's definitely higher among low income populations. And the fact that we've seen in some of our studies that people who are lower income have bigger success in improving their health behaviors with lotteries likely is a reflection of that.
Yeah, interesting. Maren's going to launch the answer to this poll, Kevin. I always think a good test of these poll questions is whether or not we can pick up interesting variation in the audience. And take a look at these findings. You'll see 30% are thinking about lowered cost sharing for higher value services. Very few on the raising for lower value. And the majority here did a combination of A and B. And then 26 did neither. Any reaction to the state of the field right now based on at least our audience today?
Yeah, no, this is interesting that this is a solid percentage of people doing A and B, higher than I might have guessed, which is good. And probably those of you who are on the call are not a representative audience. You're much more steeped in this space than many other people are. But we've seen historically a much higher percentage of lower cost sharing for high value services than we have seen raised cost sharing for low value services, which I think going forward, that's going to really shift, because the way you can fund the lower cost sharing for high value services, of course, and keep programs cost neutral is to raise cost sharing for low value services. So it's a way to, in essence, develop more value for the amount that's being spent on health benefits and health services. So I'm happy to see that the percentage doing a combination of A and B is pretty solid.
Yeah, great, interesting, Kevin. We're going to launch yet another poll question, and I've got questions in between that. The next one we're going to ask about is, based on the evidence, what method does this audience consider the most effective for changing behavior? We'll see if you bias this sample some with your great rundown and overview of all the ways you guys are studying incentives, but I'm going to give this our audience a choice to say which they consider most effective: attainment incentives, you get something for doing something; these deposit contract incentives that you guys are, I think, leading on in terms of helping us understand that; the lottery incentives that you also just described a bit; or D, tailoring methods according to demographic group differences. I'm going to ask our audience not to pick that one unless you're actually doing it or have some evidence that you can do that. So we're going to go ahead and launch that poll. And while we do that, back to our fitness-oriented start, Kevin, Naomi asked, she really appreciated your answer about the sweet spot in terms of financial incentive levels for tobacco use. She asked if you have a corollary sweet spot for economic incentive with regard to physical activity. And just to try to squeeze in a twofer in terms of your thinking here, Kevin, in addition to Naomi's question about a sweet spot for physical activity, Melanie asks whether or not you've assessed sustained behavior change in daily step populations, especially she's asking how these groups are doing 6 to 12 months or 18 or 24 months post-intervention. Do we have any data not only about the sweet spot, but also about the sustainability over some pretty good periods of time?
Right, okay. So a few thoughts on that. The amount in terms of the sweet spot, I think a lot depends on the population in question. Is this a low-risk population where this is being offered as a way to just help get people more active and, as a sort of health promotion? Or is this a higher risk group of people where there's clear economic benefits to getting them to be more physically active? So for example, in our health system now, we have a number of studies that are ongoing where people are working on trying to motivate people post-operatively to be physically active. And the reason the health system's gotten so interested in that is there are a number of shifts that have been made in terms of healthcare reimbursement, in particular the payment for hospital readmissions. Hospital readmissions, as you know, cost tens of thousands of dollars. If you can reduce the rate of hospital readmissions, that's worth a lot of money. So you can imagine in that context, you might be willing to offer pretty generous incentives. If we're talking about a population of people who, let's say, might be at elevated risk of the complications of diabetes, you might have a moderate amount of money. And if you have a totally healthy population, then it's a small amount of money. So then you're probably wondering, okay, what do you mean by a lot of money? What do you mean by moderate, small? The studies that Mitesh described, we've used an amount of about $1.40 a day. I think for a moderate risk population, that's something that could be entertained. It's about $500 a year. And if you could achieve significant increases in physical activity, many people might say that's worth it. For a higher risk population in a setting like post-hospitalization, I think it could be a much higher daily amount. Keep in mind that preventing hospital readmissions, usually people think about 30 days, so it's fairly bounded in terms of time, so the total amount might not need to be that large. Lower amount, it's hard to say. We haven't done an exhaustive set of head-to-head tests with smaller amounts trying to figure out how small can the amount be and still be motivating. I would caution that once you get to very small incentives, there is a general sense that when you pay little, it may be better not to use a financial incentive, instead use another approach, because obviously a very small amount isn't going to be seen as by the person who's receiving it as very exciting. This is part of why we use lotteries in some of these cases, because if you give people a guaranteed small amount, that's not very exciting. But if you have a chance at a big amount, even if it's a low probability, then at least that's something that seems worth going after, and it certainly gets people's attention more powerfully. I guess an interesting example of that actually is we found sometimes when we do low probability lotteries that there are concerns that we're offering people too much money. And I've always thought this is sort of ironic and sort of proof of the value of this approach, because the amount of money per person might be 50 cents. But, you know, if you're offering a 1 in 2,000 chance at $1,000, they say, but you're offering $1,000. And you say, no, on average, we're offering 50 cents. But it sort of precisely proves the point that the $1,000 is what gets people's attention, even if the odds are very low. So a lot of what behavioral economists are doing now in the context of incentives is really trying to think about how do we, in essence, get more bang for the buck. Particularly if you don't have a lot of money to work with, it's useful to think about how do you make the incentives seem more attractive, because if it was just a straight dollar amount that was 100% guaranteed with no behavioral twist to it, then it might not seem that attractive.
Mm-hmm. Yep. Hey, Kevin, are you seeing the results of this last poll? I know that in writing this question, I was as interested in our participants' answer as I was even more interested in your answer as a scientist. And again, we captured some very interesting variation here. We're asking our colleagues what's most effective, and you can see that it's pretty darn balanced across the board with a bit of a tilt towards, well, I'd rather tailor according to demographics. I want to hear how you would have answered this poll, and then I'm going to push a little bit on this 36% who say tailoring is most effective. Given what I think I've heard from you so far, do we have enough science to conclude such?
Okay. Well, it's actually a difficult question to answer, and I don't know if it was meant to be a difficult question, but in the sense that, you know, so let's say we compare attainment incentives and deposit contract incentives. If you look at our work with CVS, one of the things you'll see, as I mentioned, is that the quit rates among people who are willing to put their own money at risk are very high, but a small percentage of people might be willing to put their own money at risk. And we've seen that in a variety of other studies. We've done a variety of tests trying to get that rate up, but that trade-off often exists. So if you said, which is more effective, I think a lot depends on, you know, how much are you asking people to put up front, how generous is the match, how well is that communicated, and based on that, you could go either way on the attainment incentives versus deposit contract incentives when you're comparing effectiveness across a population of people, where the attainment incentives have the advantage that 100% of people are in play. Now, comparing with lottery incentives, it's also an interesting question, because a lot depends on how big the dollar amounts are. As I was saying, if it's a very small amount of money, I think you're much better off using a lottery, because then at least there's a chance of winning something exciting that will get people's attention. On the other hand, if you're giving out a very large incentive, so let's say you're giving $750 to people who quit smoking, I probably would just go with the, you know, making it guaranteed. Though one of the interesting twists to that we've been exploring is giving a substantial portion of it guaranteed, and then on top of that, a lottery type reward, you know, which is a way to get people even more excited about the potential of winning something substantial. So I think a lot depends, in terms of my answer to this question, depends on the specifics of how much and for whom, and what type of activity is this ongoing, is it one time? So it's, you know, I guess guess this is the challenge of being a scientist is you start thinking about all these different parameters but if you want a simple answer, it's hard to give a simple answer sometimes to a question.
Yeah, I love that answer actually, because I do feel like there is this tension. It's probably a healthy one between those of us who have to administer these programs or benefits leaders who have to make a decision on any given year, and folks like you who are actually in search of truth and would be hard pressed to try to give a simple answer. So I was tracking and totally appreciative of all your reactions. We're going to probably have time for just one more poll question, Maren. So if you could give me the screen back and let me remind our audience that last year in 2016, NBGH, National Business Group on Health, did a survey that was indicating financial incentives for wellness, specific here to worksite wellness, not some of the healthcare systems work that Kevin described earlier, that the incentives use was waning, that fewer employers were using financial incentives. Why is that? So I'm appreciating this might be also a frustrating question because it's forced choice and some of our audience might think their answer isn't on there, but let me at least give you a try. They haven't been effective, might be one reason employers are waiting a little bit, or too much backlash. You've certainly seen some of the journalists, this is some of their favorite whipping boy topics in wellness sometimes, or too much negative press from media. So one might be the backlash from the employees, one might be from the media, or we've simply moved on to other engagement strategies, or E, I really have no idea why it might be waning. So Maren, why don't you launch that poll? We didn't get as high a percent participation on that last poll question, so I'd urge our audience to give Kevin and I something to react to by giving me the highest response rate so far. As we're waiting for that, Kevin, again, also great questions coming in from our listeners. Casey Gardner has been patiently waiting for an answer she did early on based on Dr. Patel's use of the 7,000-step goal. And she has a rather lengthy question, but essentially she's saying, you know, that's kind of a ceiling that's very discrete and finite, and what would it be like if we put in an incentive system that actually just rewards progress? So she's saying, have you ever done research on something more related to a continuous measure rather than a fixed measure in terms of attainment, and might that be more effective? Because the nature of her question is we're losing out on these folks for whom 7,000 just feels like it's too big a goal as much as it's the right clinical goal, is it the right behavioral goal?
Yeah, that's a great question, Casey, and thank you for asking that. We've actually done a number of studies since then where we have used incentives that are tied to progress. We've also done a number of studies where we're allowing participants to choose their own goals. And we're giving them sort of a set of choices so that they can choose, for example, a 30%, 40%, 50% increase, or write in their own number. And one of the things that's interesting about that, this isn't published yet, but one of the things that's interesting about it is people consistently are choosing goals that are more ambitious than would be economically rational. So let's say, for example, I'm eligible for an incentive. I would pick the lowest possible target because I want to win the incentive if that's all I cared about. But we're finding a lot of people are picking the more ambitious goals, which I think is a reflection of the fact that a lot of people who are participating in these programs actually want to achieve those goals and want to push themselves harder. And it's a form of pre-commitment, in a sense, to pick that harder goal and then try to hold yourself accountable. But I think implicit in your question, which is important, is that it's nice to give people an option of feeling like they're picking their own goal, and that matches better in terms of harnessing some of their intrinsic motivation.
Mm-hmm. Yeah, terrific. So Maren's going to launch the final poll here, and then we do have a couple more questions, Kevin, and we're going to wrap things up. We really appreciate your staying longer because our audience certainly is hanging in there with us quite well. So you'll see that this also has some variation, with 44% saying that they feel, at least from their vantage point, that they have not been effective. A few saying the backlash. I'm interested to see that hasn't been much of a threat, at least for the practitioners on the phone. 30% saying we've moved on to other engagement strategies. 11% saying I really have no idea. What's your take on whether or not you're probably like the surgeon who works on cancer, you think cancer is everywhere, and that incentives are probably everywhere based on how immersed you are in them, Kevin. But what's your sense on the two levels? One, do you see them waning when you consult with companies? And then two, what's your reaction to these findings?
Yeah. Well, I think the first thing to say is I'm not convinced they actually are waning. When you look at health benefit designs, of course, every single employer, every employee who has health insurance has a benefit design, and it's a package of incentives. So that has not changed. I can't imagine that will ever change. We're not going to take the underlying incentives and cost-sharing mechanisms out of health plans. So, the question of then, when we think separately about incentives for health behavior, the rates of use had gotten so high in the National Business Group on Health surveys that I think if we see blips up and down, I'm not sure that represents a new trend. If we see that it's gone down a bit from the peak, this may just reflect that we're at a pretty high level, and depending on the sampling frame of the survey and who exactly responded this year, we're going to see some blips up and down. So that would be my first comment. Second comment is, I think it's interesting that a lot of people feel like they haven't been effective. Part of what we've observed is that a lot of what's been deployed has not been particularly well designed, and thereby probably hasn't been effective. So, for example, Paul at the outset called out one of our early studies that showed that premium adjustment has no impact on obesity. And a lot of what we see in the field is that people are adjusting premiums and assuming that that's going to cause these changes in health behavior. But there's several reasons why premium adjustment doesn't work from a behavioral standpoint. You're basically burying these incentives within much larger sums of money, basically people's health insurance premiums, which are then paid out in conjunction with their paychecks. So it's even more invisible, and then that's electronically deposited in the bank, so people don't see that $50 or whatever it is coming to their account. It basically makes it disappear. So to the extent that a lot of people use premium adjustment and similar approaches that aren't behaviorally designed, I'm not surprised that people say, what I observe is not effective, but of course that doesn't mean that a well-designed program couldn't be effective. And then in terms of other engagement strategies, that's also interesting. I'd be curious what sort of other engagement strategies people are doing. We've been doing a lot of testing around social incentives and gamification and other approaches as well. But I think as long as employers are providing health insurance, financial incentives are going to be a big part of benefit design, and I can't see how that's going to change. Paul, I'm not sure if I'm the only one who can't hear you, but I'm not hearing you.
Yep, sorry, I had it on mute as Maren and I were talking. Thanks, Kevin. Let me wrap up with an impossible question, I know, but when I see those results, I think about culture, and I think about the biggest detractors of individual approaches to wellness. I always sort of have this very flippant, just improve the culture kind of response, as if these two are somehow in competition rather than totally complementary, as of course they are. But I do get interested in the cultural differences between organizations and the readiness for the use of incentives based on the type of culture. One with a high perception of organizational support by employees might be more conducive to the use of incentives than one that already feels heavy-handed or coercive or really, is felt by the employees as not really being all that interested in their well-being. Any research on the horizon or any studies that come to mind for you around this ethical question about the differences between culture as it might mitigate the effectiveness of incentive systems?
Yeah, I'm not sure I've seen good studies. I mean, people talk about this a lot, and I think having a culture that's supportive of health and wellness is obviously important for a lot of reasons. I think another element that's related to that, to both culture and effectiveness of incentives, relates to how good the health promotion infrastructure is within an entity and how well positioned an organization is to implement whatever is designed. Because, so for example, let's say you have a really great communications infrastructure for communicating with your employees, then you can roll out a program that has a chance to work. If you don't have a good communications infrastructure, it almost doesn't matter what you roll out in terms of incentives or other programs, because if employees don't know about it, then obviously they're not going to respond. So I think, culture manifests itself in many ways, and it is an important element. It's hard to, it's obviously not as simple as any of us might like to say, okay, how do we change the organizational culture and make it more supportive of the health promotion efforts? But it's obviously work that a lot of you are engaged in, and I think it's incredibly important to do regardless of how you design these programs and implement them, because it's going to be an important factor in their success or lack thereof.
Yeah, great. Well, we are at the top of the hour. I am so grateful. I'm grateful that positive psychology principles are trending hard in this field, because they're certainly compatible with your good work, but they also make me mindful of how important it is to have people like you doing the work that you're doing, Kevin. You're just a superstar, and you're contributing mightily. So thank you for your amazing productivity and for making time for us today. So with that, we're going to be adjourned.
Sure. Well, thank you so much, Paul, for inviting me to do this, and thank you all for the chance to talk with you today.
Great. Have a great day, Kevin. We're now adjourned. Thanks all.